it is very important that we know that the final aim of our patient is to have a take-home baby, not just most of clinicians regarding the success is the clinical pregnancy rate, but for the patients, the live birth rate or the take-home baby, this is most important. We'll talk about how to improve live birth rate in PCOS patients. According to the WHO, PCOS is the most common cause of anovulatory infertility. Women with PCOS are typically more difficult to stimulate in a controlled manner, whether you are intentionally want to induce a monofollicular or a multifollicular response. They are more likely to demonstrate resistance to stimulation, and this is maybe unexpected, but some PCOS patients are very resistant to stimulation, or maybe exaggerated response, so they may have a high cycle cancellation rate in addition to the inherent risk of ovarian hyperstimulation syndrome. Of course, as we mentioned in the last webinar, that most people diagnose PCOS by the Rotterdam criteria, the well-known criteria to diagnose PCOS after having 2 out of 3 hyperandrogenism, either clinical or biochemical, menstrual irregularity, and polycystic ovarian morphology. Now we'll start about what are the variables and the predictors of pregnancy in PCOS patients. And first we'll talk about age, which is one of the most important indicators of success in our cases. It was found that in PCOS patients, there is a slower age-related decline in treatment outcomes after their first IVF cycles, which means that in this study on more than 3,500 PCOS patients, and they compared them to more than 18,000 patients with tubal infertility, and the main outcome was the cumulative live birth rate. It was found that in PCOS patients above 40 as compared to non-PCOS patients, the implantation rate in these older females is higher, the clinical pregnancy rate is higher, live birth rate is more than double that of non-PCOS patients, and the cumulative live birth rate is also more than double. We are talking about 50% cumulative live birth rate in patients above 40. These rates were comparable among PCOS patients which are even between 35 and 40 years old. So the changes in the implantation rate, clinical pregnancy rate, cumulative live birth rate were slower for PCOS patients than non-PCOS patients. Among PCOS patients less than 35, BMI significantly decreased the cumulative live birth rate. However, among older patients, older than 35 years, BMI was not an important variable, but the number of retrieved oocytes was significantly associated with cumulative live birth rate. So they concluded that the decline in treatment outcomes with age is slower for PCOS patients as compared to non-PCOS patients. For patients over 40, PCOS have a reproductive advantage over non-PCOS patients. So when you have an older PCOS patient, please inform this patient that being a polycystic ovarian syndrome patient, this is something good at age above 40, and she's happy of this diagnosis because her pregnancy rate is better than that of the non-PCOS patient. Also, in younger PCOS patients, you need to decrease the BMI before starting your cycle in younger patients. While in patients above 35 years, PCOS patients, you don't have time to decrease their BMI. Also, decreasing the BMI in this subgroup of patients, those above 35 years old, does not increase your live birth rate. Now, regarding AMH, and this is an astonishing study that just published this year, found that in cases with very high serum AMH PCOS patients, the pregnancy rate decreases. They categorized the PCOS patients according to the percentile, to those with AMH below 3.3 and those with average AMH between 3.3 and 8.2, and with those with very high AMH above 8.2. They found that low serum AMH women had significantly greater live birth rate odds as compared to those with average and high AMH. So here the AMH is a negative predictor value. High AMH, this is a bad predictor for pregnancy and for live birth rate in these patients. even after adjusting for confounders. AMH, extremely high levels of AMH, is a bad prognostic factor. Lines of management of PCOS include lifestyle changes, oral agents, gonadotrophin stimulation, laparoscopic ovarian clearing, and IVF or EGS. First, we'll start with lifestyle changes. In a very recent study that will be published next month, they found that high BMI and high total serum cholesterol were significantly associated with lower live birth rate in PCO patients. And delaying fertility management to improve the lifestyle is better, especially in cases stimulated by clomiphene citrate. And this study included lifestyle modifications, including caloric restriction, anti-obesity medications, behavioral modifications, and exercise. And data indicated that improved ovulation rates and live birth rates when patients were delayed the fertility management till improving their lifestyle. And so it's better to wait before immediate start of oral agents. BMI and the effect of BMI, there is also a question, does it affect the oocyte quality or the endometrium or the perinatal outcome? So to answer this question, there are studies that examined the effect of BMI in freeze-all cycles. First, this study that was done on more than 3,000 PCO women, and all were for freeze-all strategy. The live birth rate was most favorable in the underweight and the normal weight cohorts, and progressive decrease in BMI had a worse outcome. So obese cohort has even a high early miscarriage rate. So even in frozen cycle, lower BMI is better, and high BMI will lead to lower pregnancy rate, high miscarriage rate, and low live birth rate. However, another study that was published also in 2019 found no effect in frozen cycle for the BMI. So in frozen cycle, it is still debatable, but in fresh cycle, it's better to improve your BMI before starting your cycle. So according to the guidelines, pharmacological anti-obesity agents should be considered an experimental therapy in women with PCO for the purpose of improving fertility. Also, bariatric surgery, as we all know, this is very common nowadays, but in the context of improving live birth rate, bariatric surgery is an experimental surgery. Okay, in morbid obese PCO patients, bariatric surgery may improve a lot of things, but it can't be done only to improve live birth rate. Regarding oral agents, we'll start talking about insulin sensitizers, especially metformin, and in a Cochrane database in 2017, metformin alone found to be beneficial to increase live birth rate. So this may be a solution for patients who can't come for follow-up or traveling away. Even prescribing metformin without any other oral ovulation induction agent increases live birth rate as compared to placebo. So metformin could be used alone in women with PCOS with an ovulatory infertility and no other cause to improve ovulation, to improve pregnancy, and to improve live birth rate. Although women should be informed that there are more effective ovulation induction agents. So enough metformin alone is okay, but you should inform your patient that it's better even to take metformin in addition to clomiphene citrate or in addition to letrozole. Cochrane 2017 found low quality evidence that adding metformin to gonadotrophins increases the live birth rate. So according to evidence, metformin alone is effective, metformin with oral agent is effective, metformin with gonadotrophins, all of this will increase your live birth rate. Metformin, even there is some studies that metformin in IVF or EFRE cycles. There is no conclusive evidence that it improves live birth rate, but there is an evidence that it decreases the risk of ovarian hyperstimulation and increases the risk of the incidence of clinical pregnancy rate. So giving metformin during stimulation for the IVF cycle, according to the Cochrane, it doesn't increase the live birth rate, but it increases the clinical pregnancy rate, and it definitely decreases your ovarian hyperstimulation syndrome. So the bottom line is you should give metformin to all cases. Metformin alone, metformin with oral agent, metformin with gonadotrophins, metformin in IVF exit cycle. If you are going to compare letrozole to clomiphene citrate, according to the evidence, there are 13 randomized controlled trials comparing letrozole to clomiphene citrate, and it was found that letrozole has a better pregnancy rates and live birth rate, and that's why letrozole now moved to be the first line pharmacological agent instead of clomiphene citrate. What about gonadotrophins? According to evidence, gonadotrophins were available and affordable, should be used in preference to clomiphene citrate combined with metformin for ovulation induction. So, gonadotrophins gives higher live birth rate when compared to oral agents. But definitely, you should know the price, the safety profile, the increased risk of ovarian hyperstimulation syndrome. In addition to, you should follow up these patients. Oral agents can be given even without follow-up. So if you have the facility for follow-up, no problem regarding the cost, and you are very cautious regarding hyperstimulation syndrome, gonadotrophins offers higher live birth rate than the oral agents. In addition, as we mentioned before, it is better to add metformin to gonadotrophins, not only as aiming at decreasing hyperstimulation syndrome, but also aiming at increasing your ovulation rate, pregnancy rate, and live birth rate. What about ART? ART represents the third line of management of PCO patients. While a high number of oocytes is usually obtained during ART, there are concerns that quality and the maturity of these oocytes may be compromised. Despite this, live birth rates after ART in women with PCOS seem to be comparable to those of women with other diagnoses. So, you will have more oocytes. Maybe you will have a lower quality. Maybe you will have a problem in oocyte maturity. But the high number of oocytes will counteract this bad effect. So at the end, the live birth rate in PCOS after ART is comparable to tubal factor, is comparable to unexplained infertility, is comparable to mild male factor infertility. When you are doing ART, give agonist or antagonist. The Lambert study, the meta-analysis, the very elegant study that categorized the patients to low responders, intermediate responders, and high responders, found that agonist and antagonist have comparable pregnancy rate and live birth rate in PCOS patients. However, there is a marked reduction in hyperstimulation syndrome, the relative risk of 0.5 after using the antagonist protocol. So here we are using antagonists not to maximize the live birth rate, but to minimize the ovarian hyperstimulation syndrome. And you are doing this without decreasing your live birth rate. We mentioned in a couple of webinars the different phenotypes of IVF, of PCOS. And there are 4 phenotypes of PCOS according to the presence and absence of different criteria of the Rotterdam classification. So if you have all 3 criteria, this is category A. If you have oligo or anovulation plus hyperandrogenism, this is category B. If you have hyperandrogenism and polycystic ovarian morphology, this is C. And if you have oligoovulation plus PCOM without hyperandrogenism, this is category D. As it's noticed here, hyperandrogenism is present in the first 3 categories. This study compared the different outcomes of IVF according to the classification of patients according to different phenotypes, and they found that live birth rate after fresh transfer of all fresh and of vitrified embryos, so we are talking about cumulative live birth rate, were lowest in the subgroups with hyperandrogenic PCO, which are phenotype A, B, and C. So as compared all patients with hyperandrogenism, which are subgroups A, B, and C, have lower live birth rate as compared to subgroup C. This meta-analysis, they looked at different factors that affect the outcome of ART in these patients. They found 41 studies comparing PCOS patients, and they found a low to moderate quality evidence that antagonist protocol is preferred, and as we said, not to increase live birth rate, but to decrease OHSS. They also found a low quality evidence from 10 studies that metformin has a positive effect on live birth and ongoing pregnancy rate. This conclusion contradicts the Cochrane that said that metformin only decreases hyperstimulation without increasing the live birth rate, but they, in this study that included 41 studies, this meta-analysis found a positive effect of metformin on pregnancy rate in cases prepared for ART. Now, our take-home messages: the decline in treatment outcomes with age is slower for PCOS patients as compared to non-PCOS patients. High AMH is a negative predictor for live birth rate in PCOS patients. Lifestyle modifications improve live birth in patients stimulated by oral agents. Bariatric surgery for the sole indication of increasing live birth rate is considered experimental and it's not approved by guidelines. Metformin could be used alone or with oral agents. It can be also used with Gonadotrophins for cases prepared for time intercourse or IOI. In IVF egg cycles, metformin doesn't increase live birth rate but decreases ovarian hyperstimulation. This conclusion is according to the Cochrane, not according to the meta-analysis. Letrozole should be used as the first-line oral agent as it offers higher live birth rate compared to clomiphene. Gonadotrophins result in higher live birth rate than oral agents, but cost and safety should be taken into consideration. GnRH antagonist and the agonist protocols have comparable live birth rate, but the antagonist is preferred for safety considerations. Thank you very much.